Hello friends, this is Dr.Apurv Mehra with Dr. Mathew Varghese, and I have been asked this question many times in my career that sir, I like orthopedics but now I have a good rank and I'm also getting radiology and I'm also getting orthopedics. What should I do? I always tell them choose what you are passionate about, you will do very well in that. Your altitude in your career will depend upon the hunger you have for whatever you desire. And if you really love a subject, never compromise or never change your subject just because you're getting something else. So, what do you think, sir? What are your views on the same?
Yeah. I think you need to be clear on why you want a subject. Once you're clear on that, then you have to see, can I excel in it? So I like orthopedics because when I had my posting in third year, there was a fantastic teacher, you got a bias there. Or somebody in your family or some teacher that you look up to and you want that. Or perhaps you think that radiology is there, the toppers go there, so you go with the herd. That the topper goes there, so I have to go there. When I chose orthopedics in those days, the toppers never went there. I had a conscious decision of orthopedics chosen because I liked it, and also because I was good with my hands. I could do things with my hands, and I recognized that I can do things with my hands. So remember, any surgical specialty that you choose, double check, are your psychomotor skills good or not? I have seen people, excellent academician, but very poor surgeons. I have seen excellent surgeons, but very poor academicians. But the combination of good academics and good orthopedics with surgical skills that are equally good, that is a sparing number. So you have to be very clear first. What is your first love? Orthopedics? Because you love orthopedics as a subject, it's fascinating. It is a fascinating subject. I would never choose anything else. Because
Given a chance again,
I'll redo the whole thing. It's so fascinating. The breadth of it, you deal with the whole body. And the systemic implications of an orthopedic disease and the orthopedic implications. I diagnose in my clinic more diabetics than probably an average physician. I diagnose more hypothyroid than an average person. I diagnose more, renal tubular diseases and other diseases than an average person will ever do, or a pediatrician will ever do. Because the spectrum is so wide and you can still specialize. You can be an arthroplasty surgeon. You can specialize in hip, you can specialize in knee, you can specialize in spine. I mean, the sky is the limit in terms of the range that you can do with orthopedics. So if that is what is exciting you, please, nothing like orthopedics, go ahead. Radiology, equally exciting. Imagine, the person who is the radiologist has to be a good obstetrician, because only then he can give a correct opinion. He has to be a good neurosurgeon, only then he can give a correct opinion. He has to be a good spinal surgeon, because only then he can give a correct opinion. He have to be a good osteologist in terms of all the bones. Ultrasonography, my God, it's a complete different. So if you're thinking of radiology, because you can make money there by doing few MRIs, and then you're in a different bracket altogether. You should see where your heart lies. If your heart is in the subject and you're ready for the range and breadth of it, radiology is not an easy specialty to excel in. General radiology is very difficult to excel in. I still remember during my MBBS days, Dr. Saha, my God, what a man. What he would make a clinical diagnosis, near clinical diagnosis, just looking at an X-ray chest. Just looking at an X-ray chest. You will tell us, go and look at the heart of this patient. You will find something there. That was the level of excellence. So if you want to excel, as Apurv just mentioned, whatever you choose, think of excelling, think of being outstanding. But the surgical branch has a little catch there. If you know you're not good with your hands,
Right.
don't choose a surgical specialty, because you won't become a good surgeon then. All good surgeons are not good teachers. All good teachers are not good surgeons. And good teachers and good surgeons, the combination is
Very little.
the Venn diagram intersection that you learned in school. More your Venn diagram circles, lesser your area of intersection. So you have to be very clear what you want. So surgical branches, choose if you're good with your hands. And that you'll get to know if you're doing a olden days house job. These days, after internship, you straight goes. You don't get an opportunity to test your skills. So how do you test that? Psychomotor skills in video games and all, that's different. But psychomotor skills and other things with hands, that you have to think. Are you ready for that?
The second question, sir. You are at a place where we have got DNB Orthopedics, and I always tell them, go to St. Stephen's. You would love orthopedics and you will be very good surgeon there. Along with your DNB would be well equipped. But the question they ask is MS Orthopedics and DNB Orthopedics equal? Second, if I am getting MS Orthopedics in a peripheral college and DNB into a central place, what do I prefer? So how to really make a choice?
The choice yesterday, means in the past decade that has gone by, was straightforward. Straight away choose MS. Because in terms of value and skills that you get in MS in a government medical college is far better than anywhere else, any private institutions. Things have changed now. What has changed? Two things. One, if you have done DNB, you were writing off your career as a teacher in olden days. So if I wanted to be a teacher, a DNB qualification was not recognized. So if your long-term goal is to be a teacher and you get MS is any day preferable. Because your recognition by MCI, things may change. By MCI was that you have to be MS to be a teacher, a professor, assistant professor in a medical college. Therefore that choice was very easy. But now, the options have opened up a little. How is it opened out? If you've done a DNB from an institution which is not a medical college, but you get as a registrar to work in a teaching hospital medical college after DNB. You've done your registrarship, senior residency, and you have experience of at least 2 years or so, then you can still be considered as a teacher's interview for selection.
Right.
So there is an opening up that has happened. Things may change further. I do not know how it's going to evolve. So what is your lifetime goal? Your lifetime goal is to be a good orthopedic surgeon in practice. It matters where you train. To be a good orthopedic surgeon, you have to be trained to be doing a spectrum of conditions and then narrowing into your interest. That you choose a good institution. These days, there are many good institutions offering very good training programs, very good surgical exposures, which many of the government institutions cannot match. Therefore, if you're very clear, because getting government institution registrarship is not so easy. So, if you're very clear you're going into practice and you want to work under a good center, good training and go there, well. If you're very clear that you want to be a teacher, ultimately MS would probably be your choice. But remember, where you train will lay your foundations. People choose, here I get a lot of surgery, I must go there. Lot of surgery without supervision, you end up with very poor surgical dissection skills, very poor fundamentals, very poor basics, and they don't make good surgeons.
So surgery.
The most important thing in surgery is not just the knife, the decision making skills, when to use the knife and when not to use the knife. As they say, a good surgeon knows when not to use the knife, not merely when to use the knife.
I've been taught this line throughout my career by Professor Sudhir Kumar, who taught me during my residency, if you are a good surgeon, you will know how to operate. But if you are a great surgeon, you will know when not to operate. And there lies the difference. And you have also answered my third question, sir. I am getting my MS degree into a college which gives me a lot of surgical exposure as compared to a place which gives me a balanced surgical plus academic experience. So sir has answered it. You need to know how to do it, what to do it and what not to do to become a good orthopedic surgeon.
A lot of young postgraduates who have passed out from good institutions make this mistake of becoming a registrar in a high volume area with very poor supervision. You end up making judgments and decisions which may be faulty, which may be under peer pressure, which may be not the best of things to be done. Because they have gone to a workshop, they'll come back and try that skill out. So the patients become the guinea pigs. Your ethics go to the underground area. So you need to be ethical, you need to think of the patient, and then you will be sure that you get the right fundamentals in place, when to operate, when not to operate, how to make ethical decisions, how do you make a judgment which is patient-centric and not money-centric or surgeon-centric to cut all the time. I'll give you an example, and that happens very often. One country, I'm not naming the country, where shoulder surgeons are there, when they audited, they found that there's a 600% increase in a particular type of shoulder surgery. Immediately, the association of these surgeons in that area ordered an audit. Is it really true that the one procedure can go up 600%? There's some catch there. Either it is money, or it is newness, or it is technique without knowing the long-term results. One big problem with orthopedics is, if you keep changing institutions, patients wouldn't know where you have gone, and you wouldn't know the long-term results of some of the things that you've done. Staying at one place and following these patients up. Don't go by the immediate results. Immediate results may be outstanding. And the classic example is clubfoot. Immediate result of surgical intervention in clubfoot is outstanding. Parents are happy, you are happy. But the long-term results are not good. So unless you have long-term follow-up with somebody who has done good work over a long period of time, long body of experience, good academic exposure, good decision-making skills being transferred to you, and is a good mentor, I would choose that. That is your.
Right, sir. Now, the next question, sir. Before I go to the last question. I have joined MS or DNB. What should be my goal in the first year? What should be my goal in the second year? And what should be my goal in third year? How to take up the residency sequentially? So what should we do in the first year, sir? A first year resident,
there is no sequence here. It is difference between Kite's method where you did sequentially and Ponseti's method where you did simultaneously. There is nothing like sequential learning in MS or DNB. The only difference that is there is when you're in the first year, make sure you have your basic fundamental clinical examination thoroughly read and done. Other than that, what you do in the first year is not different from what you do in the final year. And what is it? Patient-centric learning. Every patient that you see, don't look at him as, oh my God, one more patient. Remember, I'll give the classic example of Dr. Chittaranjan Ranawat. He trained from Indore, and residents that trained with him, along with him, had one thing to say about him. He was always wanting to do duties, and we'll exchange duties with you. You're happy because you get a free day. Right. And you'll wonder why this man is wanting to do that. Right. Because every day extra spent in the ward, every hour extra spent in the ward, not a clerical time spent, no. Not filling notes which are useless, not doing dressings which are good, you should do it, do it the right way, but quality time. Okay, this is the new admission. New admission, okay, what is the diagnosis? Okay, the registrar made this decision. Why did he make that decision and not this decision? Read on every case right from day one. Don't leave it to the third year, I'll start reading. No. Day one. Today I have a patient of renal tubular acidosis admitted in my ward. But that postgraduate may not see that such a case for the next of his entire posting.
Maybe longer.
Maybe longer. There are some syndromes that are there which you may never see ever in your life. Mow your database within your hard disk between your ears. Better are you as an orthopedic surgeon. So you're learning the foundations of clinical examination should be your hardcore core in the first 3 months.
Right.
But after that, what you do is day in and day out the same. You've seen this patient in the OPD, don't leave it to the next week. Same day, evening, go and read the book.
Right.
Even today, even it is 1 a.m. in the morning, I have a patient which I couldn't understand. I tell the patient, be honest with your patient.
Right.
Tell the patient, I'm sorry. Because at my level, I get very rare syndromes. And many of them I have not even heard the names. Don't be ashamed of admitting, I'm sorry, I did not know, I'll have to look up. I've seen similar cases, not a problem. But this case may be different. I don't know the outcome if I operate. I think I can do operation. I think I can do good for you. But I'm not sure of the long-term iron. And I'm not going to put my knife on you unless I've gone back and read and then come back. So keep reading every day on every patient that you see every day till the last day of your life, not your post-graduation. Your learning doesn't end with your post-graduation. It just gives you a license to do something, and license to do something is not the end of life. Your skill and excellence and being outstanding depends on how well you keep abreast till the last day of your life. And that's what differentiates a Dr. Tully from somebody else. That humble man keeps reading and keeps going back and keeps questioning. And don't forget to keep questioning. Why did he make this decision and not? Why is he operating now and not later? Why is he operating 10 days down the line, not earlier? Why is he doing this? Why is he using this implant and not something else? Question. There are no wrong questions. There are only wrong answers. No question can be wrong. You may think it is a stupid question, but Newton asked a very stupid question of why is the apple falling down and not going up? And you have a foundation of basics of physics laid down by that stupid question. By people who thought he was stupid. No, there's no question that is stupid, only answers that are stupid. Answers that are unlearned. So you have to be very clear on this.
And then comes the question that you have actually answered. Is orthopedic an end branch? So there is no end branch. The learning continues. But are we looking at the specializations? And what time do we realize what specialty we want to go in?
Don't be in a hurry.
Alright.
These are times of fast forward learning. Everybody wants a shortcut. You have SMS language, acronyms, shortcuts, fast forward, everything is fast forward. Orthopedics is one branch which you cannot fast forward into your experience and your skills. It's too wide an area. There is shoulder, there is elbow, there is wrist, there is hip, there is knee, there is ankle, there is spine, there is pelvis, there is acetabulum, there is occipitocervical region, the cervical region, you name it. And there is metabolic orthopedics, there is pediatric orthopedics, there is you have dysplasias, you have skeletal dysplasia. I mean, there is no end to it.
So
it is too wide an area. So you give time. You learn basic foundations of orthopedics first, the clinical examination first, then advance on to diagnostics. How do I get my diagnosis right? Then while you're doing that, parallelly improve your surgical skills. The more you operate, more you are confident. And remember, Nowhere in medicine is the knowledge of anatomy more important than in orthopedics. First year, please revise your Cunningham's Manual of Practical Anatomy. You have to have it inside out. If you don't know anatomy, you can't be a good surgeon. If you are very poor in anatomy, make sure if you want to be in orthopedics, get your anatomy right. You cannot be a good orthopedic surgeon unless your anatomy is absolutely sound. So, first year, to repeat what you asked me, 2 things that you lay your foundations on. Clinical examination, whether it is S. Das or Hamilton Bailey or Hutchison. Hutchison is a very useful book for orthopedic surgeons. A lot of basic neurological examinations there. Joint examination is very nicely given there. Read that, chew it up nicely. Middle of the night, somebody wakes you up. How do you do this test? How do you grade reflexes? You should be able to rattle off like that. Foundations, good. Then, other than that, from first year to third year, every patient is a textbook for that particular disease for you. Read up, chew it up, question, get your answers right, go back and read, come back. I had my Campbell's Operative Orthopedics with me in my bag. I have a habit of carrying a bag all the time. How did that come about? I always had Campbell in my bag. So if you open my bag in the side room which was lying there always, there was always a Campbell there. And I literally chewed up my Campbell every time. I've done the procedure 10 times. Again, before going to the theatre, I'll read it again.
And you'll get something more out of it.
And I didn't realize this. I missed this point. Reading on every case, right till the end of your life, is the life of an orthopedic surgeon.
It's life of a doctor. So you learn every day. The day you stop learning, you die. And with that, I would like to conclude this. Thank you very much, sir, for illuminating us.
Pleasure.
Thank you. Thank you very much.